Welcome everyone to the MRCGP SCA Study Club for May 2025. So this is session 4. For those that haven't met me before, my name is Muhibur Rahman. I'm a portfolio GP based here in Birmingham and Solihull and a consultant in medical education. I used to be an examiner and invigilator for the GMC. I sit on the NICE GP reference panel. I was involved in piloting the CSA and sat the first sitting of that back in 2007. And I've been teaching for CSA, then RCA and SCA since they came in. I also trained under the old system. So we did an exam called Summative Assessment, which involved video recordings, and also the old version of the MRCGP. There was a video component of it. And our team at eMedica have now trained over 82,000 delegates. Joining me this evening on the faculty from the core eMedica team, we have Masouda Rahman. Okay, so this is the 4th of these sessions. So those that have been before, welcome back. For those joining for the first time, welcome. I'll just go through the format. So we're going to do one sample SCA roleplay. It's an interactive case, so please get involved. So the way it will work is I will be the doctor on your behalf. So as soon as I've done the introduction, I will only ask questions that you have typed into the chat, and I will ask them exactly as you have put them in the chat. So please ask them exactly how you would like to ask the patient. And then Masouda will play the role of the patient, and she will answer your questions, and then we'll evolve, and then we'll pause at some points and sort of do some teaching, look at revising the relevant guideline. I'll ask you what you think might be the diagnosis, what tests you might want to do. Then towards the end, we'll get someone to get involved, maybe have a go at explaining something. And then we'll talk about what resources we have that can help you if you're preparing for SCA, and we'll take any questions. Okay, so there'll be a live Q&A. Use the Q&A feature for that. Use the chat to get involved in the consultation. Okay, so we're going to make a start. I'll show you the information, and the information that you'll get in the actual exam. You get a screen like this. The minimum will be that there'll be one screen with the basics of the patient. So sometimes you've got a new patient, you might not have much information on them. Sometimes like this, there's limited information. Some patients, there'll be a lot more. There might be 2 or even 3 screens worth of information. So I'll give you a couple of minutes to have a look at the information, and then the patient will come on the line. Okay. Okay, great. So what we'll do is we'll paste this information into the chat in case you want to come back to it. Okay, and you want to look at it. You might need to scroll because other people say things in the chat. It will disappear, and only the faculty will be able to see what's in the chat. As I mentioned, I'll do the introduction. After that, I'm going to ask the questions that you ask me to ask based on exactly what you've typed in the chat. So try to think ahead, and so that I'm not pausing for a long time, that I've got a couple of options to ask waiting for me. But equally, if you use a technical term or abbreviation, I'm going to say exactly how you type it. So then the patient might not understand that. So think about exactly your choice of words, right? So let's make a start, okay? Hi, is that Sabina Mirza?
It is, yes, thank you.
Hi, my name is Dr. Rahman. I'm one of the GPs here. How can I help today?
I don't know what's going on. I feel like I barely recognize myself anymore. I really just need you to help me.
Okay, so I'm going to pause there. That's the opening statement. Now, in the exam, once you've done your introduction, that opening statement is standardized, i.e. the role player will give that generally in the same way to every candidate. But what they say after will be determined by what the doctors ask. So, they will give different information based on what you ask. There's some things that might give easily, some things they might give a cue, and only if you explore the cue, and so on. So we'll go back into the consultation now. We'll carry on from there. Okay. So can you tell me a bit more what you mean by that?
I'm usually a very competent person, but I'm just not coping. I can't remember anything. Everything is irritating me. Like I'm not functioning normally at work.
Oh, really sorry to hear that. And how long has it been like this?
Months and months. If you tell me, when did it start? Maybe September, October last year. I don't know how many months that is.
Okay, so a good 6 months plus.
Yeah, yeah.
I'm really sorry to hear that. And have you had any thoughts as to what might be causing you to feel this way, these things that you're experiencing?
I mean, I have been a bit worried that I might be going the same way as my mother.
And you mentioned it's affecting your work. How is it affecting you?
I'm forgetting meetings. I'm just not showed up to a couple of places because I just plumb forgot. A couple of embarrassing incidents in meetings,
Okay.
just
And
everything. This is not who I am at work.
right. And you mentioned like your mother, you're wondering if that could be. Can I ask what happened to your mother? What do you
So,
mean by that?
my mother, she's in a nursing home. She has dementia. She's quite young for that. She's only 72. I don't know if that's, but she seems young to me to have suddenly just lost herself completely. So I'm worried whether that's something that, because it feels like I'm forgetting things. I can't concentrate. I'm not like myself.
Hmm. Right. So you worried that you might sort of also be developing dementia.
That's what's frightening me.
Oh. Oh, well, I'm really sorry to hear that concern, and I can imagine it seems like that's very difficult. Um, and I'm sorry to hear about your mother as well. Like you said, 72 is still young, and I can see that you look quite tensed. Is there anything particular that's worrying you?
Well, what I said, I don't recognize myself anymore. I'm worried that I'm losing myself or losing my mind or going to end up like my mother.
And you said it's been sort of about 6 months. Would you say it's got worse in that time?
Yes, yes, I would.
And you mentioned some of the things that had happened at work. Is it affecting you at home? How are things there?
Well, I'm not, I think I'm not very easy to get along with right now. I'm not sure I'm very easy to live with. I think it's creating some strain everywhere.
Right, okay. And was there something specific you were hoping that I could, help you with today?
I thought you would give me some medicines.
Right, okay. Can I ask, you mentioned that in terms of home, that maybe you're not as easy to get on with. How's your mood?
Well, I'm tensed, and like I said, I'm, I feel like I'm irritated all the time.
Right. And who's at home with you?
Just my husband.
Okay. Um, and have you had any hot flushes?
Yes, that is what's been happening at work. Just having to suddenly feeling so hot, I've got to take layers off in in a room full of people.
So when you said you had, embarrassing thing happen at work, is that what you meant?
Yes,
Right, okay. And
that and just forgetting to show up to places where I'm expected.
yeah, that must be difficult. Any night sweats?
Oh, yes, yes.
Okay. Any sort of awareness that your heart's beating faster than usual?
I hadn't thought about it, but maybe like when I feel hot, I feel really hot.
Okay. Any weight loss?
Not that I've noticed, no.
Would you say that you sometimes get brain fog? Would you describe it in that way?
Yeah,
Okay. Have you had a fever?
I know. I don't think so.
Okay.
I haven't checked, but I don't think so.
Any urinary issues?
No.
No. Do you drive?
Yes,
Do you feel that that's been affected at all?
just by being irritated. Maybe I'm not easy to get along with on the road either. I don't know.
Okay. So I've got a sensitive question to ask. Um, have you noticed any dryness down below?
Um, yes,
Okay. And any pain during intercourse?
yes.
Okay. Do you think that that's affecting your physical relationship?
It might be. It might be.
And is it that it, is that because it can be uncomfortable, or do you feel that you've actually lost the desire? you're not as interested?
That's part of just being irritated all the time. I don't know what's affecting what, but I
Okay.
am
So,
irritated all the time, and definitely it's not what it used to be.
okay. Are you taking any medication over the counter? I can see that on your records, there was nothing.
I don't take anything.
Don't take anything, including contraception?
I don't need to do that.
Okay. And can I ask about your periods? Are you still having periods?
Uh, I am still having them.
Okay. Are they regular?
No, not as regular as they used to be.
Okay. And how was it before?
Before, it would have been like clockwork.
Okay. And you said not as frequently as it used to be. So how is it now?
Like, I think it might be 2 or 3 months, and then I'll have one. I
Okay.
think I had one 2 months ago.
2 months ago was the last one. Okay. And you said that you don't need to take contraception. Can I just clarify what you mean by that?
So my husband has had a vasectomy.
I see. Okay. Um, how's your sleep at the moment?
Oh, I'm waking up because I'm hot just all the time. And when I wake up, I'm waking up all sweaty.
Okay. Any bloating?
No,
Any family history of thyroid issues?
I I don't know.
Yeah. Okay. Um, and can I just check? Were you up to date with your smears?
Yes, I had one. Not they sent me a letter. I came. It wasn't very long ago.
Oh, okay. And just a few things thinking about risks. Uh, I can see from your records that you don't drink, you don't smoke. Is that still accurate?
Yes.
Is there any family history of breast disease, like breast cancer?
Not that I know of. And my mum's not in a position to tell me.
Okay. And I mean, I can see that in your medical history, apart from eczema, which was when you were a child, you're generally fit and well because
I'm
we
usually very well.
don't see you very often for different things. Okay. So is there anyone in the family that's had a blood clot?
Not that I've heard about.
Okay. And any recent things that might cause you stress, apart from, of course, the way you've been feeling?
No,
No. Do you get bad headaches?
no,
Migraine?
I don't.
Okay. All right. Let me pause there. Let me share my screen and we'll talk through um, where we've got so far. Right. Okay. So well done. Between you, we've got a lot of useful information. So, one of the things here is that one of the learning points I want you to take away is that sometimes patients might be worried about one thing and they might have a good reason. You can see why she's forgetting things. Her mother developed dementia and it progressed to a level that she was not able to live independently, is now in a care home. Okay. You can see why, if now you're being forgetful, you might think, okay, these things can run in families. Maybe I've got the same thing. And so, actually, one of the things that maybe we could explore a little bit more is we could think about asking some questions to explore that. But she's young, and given some of the other things she said, it's much more likely that what we're thinking about is menopause, perimenopause, and those kinds of things, the symptoms. So, some of the things that were really important, we got the details of. So, changes in menstrual pattern. When was the last period? Is she still having periods? Was it regular before? Vasomotor symptoms, so things like the hot flushes, night sweats. Okay. Um, memory changes can happen. She mentioned that already. Mood, that can be changeable. People can be irritable. They can have times when their mood might be low. Sleep can be affected, both in and of itself, but also because of night sweats. And then we can get urinary symptoms like vaginal dryness, dyspareunia, things like that. And we want to look at the impact on daily life, both at work and at home. Then one of the things we want to think about perhaps is if you're thinking about how do we go about treating it if it is perimenopause or menopause, that some of the questions that people were asking me to ask were thinking about risks. So, good questions to ask about family history of clots, breast cancer. This patient didn't have any. Remember, we had their history. Go back to that slide. You can see that they're fairly well. They had breast screening a couple of years ago. So they haven't got personal history of breast disease. Smears up to date. They don't have any significant medical history of note, non-smoker, but family history of some of these things would be really important. Okay. Something else that we might think about, she'd mentioned that she was hoping to get a tablet, but in her mind, to help with symptoms to do with memory, i.e. she was worried about dementia. That may be actually coming up with a diagnosis and then thinking about, if we're thinking about HRT as an option, what are the different options? And we have a duty to discuss risks and benefits, right? So we're going to come on to that and we're going to practice that. Before we get to that, are there some important red flags that we want to ask about and exclude? So we asked about weight loss. Yeah. She mentioned her mood. So we might want to clarify that if they are a bit more irritable and their mood is sometimes down, that, do they actually feel down, depressed, helpless, and hopeless? Do they find no enjoyment in the things that they used to enjoy? Could this actually be clinical depression? Because someone could have one thing and also have another, couldn't they? Okay. All right. What about examinations? Now, remember, we want to make these sessions important and beneficial for everyday consulting as well as the exam. So in the SCA, you will never physically examine a patient. You're seeing them remotely, but sometimes they might give you some relevant exam findings in the information they give you here. Okay. Sometimes there might be some important examinations that you need to do. So part of your management might be to ask them to come in so that you can do an examination, right? Okay. But in real life, let's say you had this patient, this wasn't remote, they were in front of you. What things would you want to ask and do? Because if someone said something really important to ask about, she's having periods, but she's having them less frequently. Does she get any abnormal bleeding, for example, in between? That would be something important, right? And then in terms of examination, someone said blood pressure, body mass index. Yeah, absolutely. Okay, so some of the red flags and contraindications that we want to rule out. So unexplained bleeding, i.e. something different to normal. Unexplained weight loss. Screen out, are they clinically depressed or is this just some mood changes that can happen? Personal and family history of relevant cancers. And then in terms of examination, blood pressure and body mass index would be really, really important, wouldn't they? Okay. All right, let me ask you another question then. Let's say now in fact, I'll get the patient back on and let's explain what we think it might be. Okay, so type into the chat how you might want me to explain that. Oh, someone's already done that. Great. Okay, good. Right. Okay, so Mrs. Mirza, I can see why you were worried, given your mother's history, that, could this be the early stages of dementia? And things like the forgetfulness that you mentioned, that is a feature that we see in dementia. And sometimes actually, if someone is forgetting things, they might be a bit irritable and not quite themselves because of that, because they don't remember something and then they're annoyed that they've had to do it again or things like that. However, some of the other things that you mentioned, the sort of brain fog, the night sweats, the hot sweat, hot flushes, where you said that you had to take layers off and it was a bit embarrassing. The fact that you previously were very regular with your periods, but now you said it might be 2 or 3 months, it's changing, and the last one was 2 months ago. All of that fits with the perimenopause. Have you heard of the menopause?
Yeah.
Yeah. So the menopause is, when your periods completely stop, and they've been stopped for at least a year. But when someone's near that period, we sometimes see that some of the changes that are happening in the hormones mean that they get some of those same symptoms, and we start seeing things like the periods start changing. So sometimes they become a bit heavier, sometimes they become a bit lighter. They might stop for a bit, then restart. They might come not as regular as they were. And a lot of that fits. Okay. So I think that, you might be going through the perimenopause. Okay. Which means that, at some time soon, you might actually stop having your periods completely. What are your thoughts about that?
If that's all it is, that would be a big relief to me. Do you need to do any tests to be sure that's what it is and that it's not anything like what happened to my mother?
Okay, that's a great question. Let me bring that across to the team. Okay, I'll get you to jump offline for a minute there, Masuda. Right, okay, so she's asked about tests. Do we need to do any tests? If so, which tests? Let me give you a list of some options, and you let me know in the chat. Are there any of these that you'd like to do? If so, which ones are relevant for this particular patient? Just a reminder, she's 52. Okay, so we've got options of FSH. Some people have said that it's just a clinical diagnosis at this age, no test required. The most popular one that people have said that say that they need tests is FSH. Okay, so yeah, it is a situation where actually that's something that sometimes people will lose marks for, is that sometimes people will say in the exam that they want to do tests, and sometimes that will be prompted just themselves, sometimes it'll be prompted because the patient's asked. That sometimes people will do tests that are not necessary or that the guideline says you shouldn't do, and you'll actively lose marks for that, because one of the feedback statements is about inappropriate use of resources, so doing tests that aren't necessary, for example, or giving treatments that aren't necessary. Okay, so there's no investigations needed for this patient. So what's the diagnosis now? Yeah, perimenopause, right? So we can diagnose perimenopause without testing if someone is 45 and over, she's 52, and they've got vasomotor symptoms, which she's got, and they've got recent changes in menstrual cycle. So she's got all of those, right? She's over 45, she's got vasomotor symptoms, she's got recent changes in her menstrual cycle. So then we can diagnose it without any testing, all right? Similarly, you could diagnose menopause without testing if someone has had a hysterectomy, so therefore we can't rely on the periods, but they've got the typical symptoms of menopause, or they're 45 and over and have had no periods at all for 12 months, and they're not using hormonal contraception, which this patient isn't there yet because her last period was 2 months ago. So, she might get there eventually, but in a different situation, that's what you'd need to be able to diagnose menopause. Okay. A couple of other things to think about. Just type into the chat, what's the average age of menopause in the UK? So in the UK, it's around 50, 51, 52, it's there or thereabouts, okay? It's not in the low 40s or the mid 40s, all right? Now, some people, it will be younger, some people will be older. Just something to be aware of, that broadly, on average, there's a lower age of onset for perimenopause, menopause in patients from certain ethnicities. So Asian, Afro-Caribbean, some Mediterranean, if there's a family history of early onset menopause, and certain lifelong conditions, chronic diseases can prompt earlier menopause. And then just to reiterate that, NICE specifically recommend that you don't test FSH if someone's using hormonal contraception, that you don't do anti-Mullerian hormone, you don't use estradiol, inhibins, ovarian volume, or follicular count. Okay, these things are not recommended, because sometimes people will, patients might say, oh, I want this test or that test, or they've read about it, and just because someone's requested it, part of being able to manage it confidently is to know when you can and can't give something, or when something is not needed, and so on. What about management? Okay, how would we approach management for this patient? What would be first line? What would be some of the other options? Type into the chat, and then we can talk about it. Okay, so key question is to know if they've had a hysterectomy or not, right? This patient hasn't. So in that case, if they've got menopausal symptoms, especially the vasomotor symptoms, that's probably the key question to ask is, if they've got a uterus, then you need a combined HRT. Now, there's lots of different options for that. You've got oral, you've got patches, you've got cyclical, sequential, and you might talk through different things. You might give them a leaflet to read about it. You might ask them to come back and so on. But the key is that they need a combination. If someone's got a uterus, if you give unopposed estrogen, then that significantly increases the risk of cancer, right? If they've not got uterus, so they've had a hysterectomy, then you can consider estrogen-only HRT. And then if someone was young, so they had a premature menopause, then HRT is still an option, but another option would be the combined oral contraceptive pill. And then in the latest update in the guidelines for vasomotor symptoms, you could also consider menopause-specific CBT. Okay. Similarly, if they've got some mood symptoms, well, HRT can often help settle that. But equally, if they just had mood symptoms and they didn't also have vasomotor symptoms, you just wanted to focus on that, then CBT can be very useful. And then she mentioned that she did have some vaginal dryness, so dyspareunia. So for urogenital symptoms, vaginal estrogen with or without a lubricant or moisturizer, that can be helpful. And then it sounded a lot more like it was the fact that she was a bit irritable and there was pain rather than she had totally lost libido. But you get some patients who have significant sexual dysfunction. And in that situation, tibolone or testosterone are options. Okay. Testosterone you'd usually refer to secondary care for. Okay, so it'd be important to explain the benefits and the risks of HRT. And this is one of the things that we're going to role play out, like a volunteer. Use the raise hand function if you'd like to volunteer, and make sure that you've got a camera and microphone that works so that we can get you online. Okay, but one of the things that we would think about for this patient is combined HRT because they've got an intact uterus, right? Because they've got still having periods, then a cyclical regime would be recommended. Okay, and a couple of people have said that. All right, so you could give sort of a monthly cycle, daily estrogen and progesterone in the last 10 to 14 days, or 3 monthly, so daily estrogen and progesterone for 14 days every 13 weeks, and so on. It'd be important to explain that when they first start, they may have some bleeds, and then about the withdrawal bleeds. And once they have the menopause, that you might switch to continuous HRT. And you want to review them in a few months. Remember, before you start this, you want to make sure that they haven't got any contraindications like a sky-high blood pressure, body mass index, and so on. And so we'd want to bring them in and sort that out, right? Okay, right. So in terms of a patient with sort of the genitourinary syndrome, the vaginal dryness, pain, discomfort during sex. Sometimes they'll get recurrent UTIs. This patient didn't have that. Then we can give a low dose vaginal estrogen for that. This doesn't have that much systemic absorption, so there's lots of different options. And NICE has quite a nice flow diagram that you could use and actually show the patient that you can go through. So, you can go through, is it practical to give vaginal treatment? Because otherwise you've got non-hormonal moisturizer and lubricants if estrogen's refused or contraindicated. But if not, you've got other options here. And similarly, if they've got a history of breast cancer, then you're going to think about non-hormonal options because you don't want to give the estrogen, right? So again, there's a nice little flow diagram here, all right? And some of the other things that you want to think about, she mentioned her sleep was disturbed. So lifestyle modifications, so good sleep hygiene, not to have caffeine after about midday, to have loose layered clothing, reduce the sort of ambient temperature, to avoid things that might actually make that worse. So she doesn't smoke, she doesn't drink, but she might have caffeine. Spicy foods can sometimes impact things. Some herbal remedies patients might be taking, just find out if they are taking what they are, because some of those things can interact, so we need to be a bit cautious. And then to start thinking ahead about bone health and cardiovascular health. So the importance of doing weight-bearing exercises, calcium and vitamin D supplements if they don't have a good dietary intake and aren't getting lots of sunshine and things like that. Maybe thinking about monitoring their blood pressure so we can keep an eye on things before they get there. Okay. So what I want to do is I want to have a go at explaining what you're going to start them on and see they might have some questions about HRT and see if you can answer those questions, and then we'll talk about it. So let me see who's put their hand up. So I can see the first person that put their hand up is Sintujan, Dr. Jayawira Singham. So I'm going to jump off, okay? I'd like you to start from when you're explaining the treatment, and the patient might have some questions, and we'll take it from there, okay?
Thank you for telling me that you've had these symptoms for the last 6 months. It does sound like what you have is a condition called perimenopause. Do you know? I know you were hoping for a tablet. There are certain options that we can talk about that will help you come up with a decision.
Mhm.
Have you heard about HRT at all?
Yeah, I've heard of it. Just people talk.
And do you know what are the options available in HRT?
No, not really.
Okay, because you're still having your periods. We would like to mimic your period cycle. So we would want to do something called a sequential. So it'll mimic your period cycle, and we would want to give you estrogen as well as the progesterone, both the hormones that are responsible for your periods as well. I know that you were hoping for a tablet. We do have a tablet option as well as a patch options.
I just want medicine. It doesn't matter what form it's in. If you tell me what I need, I'm quite happy to have that. Just, I did have a question about risk.
Yeah.
You said you don't want to give me, I have to have both the hormones. Is this to do with that breast cancer risk? I feel like I remember reading that HRT can increase your risk of cancer.
So there is a slight theoretical risk of increasing breast cancer with HRT, but this is relatively reduced when we give it through the patch options, the non-oral.
I feel like I don't know if there's more than one cancer that it affects. I feel like I definitely read that it doubles your risk of one of the cancers.
So yes, so with the breast, it slightly increases the risk of breast as well as the endometrium, which is the lining of your womb. But that's why we complement the estrogen with the progesterone.
Which one is it that it doubles your risk for?
It doubles the risk for the breast.
It doubles the risk for the breast.
Yes. So usually the risk, the baseline risk for a person to develop a breast cancer is 10 in 1,000, 10 in per 10,000 patients. Whereas if you're on HRT, it's 15 per 10,000 patients. So there's an increased risk of 5, but it's a theoretical risk of 50% increase.
I'm sorry, I didn't understand that. If you're increasing the risk by 5, isn't that 50%? There's definitely something where it doubles.
Yeah. So
maybe it's not breast. Is it the other? Is it cervical? Is it? There's definitely one where it doubles. Is it you mentioned endometrial? Is it that one?
I don't exactly know about that. What I'll do is I'll go back and look at it and come back and I'll let you know about the risks involved in that if that's all right with you.
Okay.
Because I don't want to give you any information that I'm not completely sure about.
Okay.
Okay. Are you happy for me to talk about the different types of HRT available?
Yeah.
That's fine. Thank you very much, Sintujan. Thank you for having gone. Well done. It's great that you volunteered. And well done. Some good things there. I'll give you some feedback on some other things that we could do to make it even better. Okay, great. So now this again highlights 2 really important things. So one of the things that hopefully has come across throughout the whole of this is the importance of knowing the guidelines. Knowledge gives you power. Like some of you clearly knew, okay, she's still having some period, so she needs to have this type rather than that type. Okay. Similarly, had thought about, okay, what are the contraindications? So therefore, we need to ask about these red flags. We need to, because a certain level of blood pressure might mean that it's not safe. Let's get them in to check their blood pressure. Let's check their body mass index. Okay. When it comes to discussing risk, this is a really, really common question, right? So it's worth actually learning how to answer this. Now, in real life, again, NICE has got some really visual aids, which I'll show you, that can make it very helpful. But I think one of the things that you could change is be careful of your choice of words. So at one point you said it's a theoretical risk. Well, it's not just theoretical, is it? It is an actual risk. But perhaps if you separate the difference between absolute risk and relative risk in language that patients can understand. I'm going to show you an example of how to do that in a minute, okay? And the visual aid can be really useful for that. That can make it clear. But one thing that you did that was really good, that sometimes someone will ask you a question and you don't know. This can happen, okay? If you really don't know, it's better to say, look, let me just double check, than to say something that's wrong. Because if you say something that's clearly wrong, because you've just had a go, what that does, it's not just that it can impact the specific mark in terms of management, because they are testing knowledge. The SCA is primarily a clinical exam. Communications, less than a third of the marks, all right? But it's just that overall it can give an impression to the examiner that if you're not sure, you're not going to take the time to check, you're just going to guess. And that worries them about being safe, okay? So this is what the patient asked, that, she'd read that HRT doubles your risk of breast cancer, or that it increases it, but one is definitely double. She might have read that in, a magazine article or newspaper or something like that. So let's look at this, okay? So the first thing is to say that, look, if we look at women in her age group, so she's 52, so between 50 and 69, over a 20-year period, we're looking at this, that someone who took combined HRT for 5 years, if they didn't take HRT at all, 59 women out of about 1,000 will get breast cancer. That's just a baseline in the population. If someone took HRT for 5 years, it goes from 59 to 79. You can see as a percentage, that seems like quite a lot. But if you think about it as an absolute number, out of 1,000 women that took HRT for 5 years, over a 20-year period of follow-up, only 20 more women would get breast cancer if they had HRT out of 1,000 compared to if they didn't. When you put it in that terms, i.e. in absolute terms, rather than a relative increase, it's not so huge, right? If they took HRT for 10 years and then we followed them up over a 20-year period, it goes up a little bit more. So, 59, remember, is the baseline out of 1,000. It goes up to 92 out of 1,000. Now, do you see, that isn't quite double. It's about 40% increase, isn't it? All right. But that's after taking it for 10 years. Again, if we look at it as an absolute number, out of 1,000 women, 33 more, if they took HRT for 10 years, would get breast cancer compared to how many would get it if they didn't take breast cancer. Again, as an absolute amount, it's not a huge increase. For ovarian cancer, this is the one she might have read about. Here, it sounds really scary. If you say to someone, actually, if you take HRT even for a couple of years, because this is for unknown duration, okay, it doubles your risk of cancer of the ovaries. That sounds really scary, doesn't it? But if you look at this in absolute numbers, this is a really powerful example. Look, if someone doesn't have HRT at all, then what happens is out of 1,000, only one woman out of 1,000 is going to get ovarian cancer if we look at it from age 50 to 54. If they take HRT, that's whether it's combined or estrogen only, and it's unspecified, they could take it for a couple of years. It's not a set period like with breast cancer, we've got 5 years and 10 years. The increase is from 1,000, it being 1 to 2 out of 1,000. You see, the absolute risk is still tiny. In total, that's still only 0.2%. It's not even 0.5%. But can you see, as a relative amount, it sounds huge because you've gone from 1 out of 1,000 to 2 out of 1,000. That's a doubling. 100% increase in risk. Sounds huge, right? This is where using the actual numbers can be really helpful. And they've got this actual visual aid. Look, all of these women won't get ovarian cancer. Okay. With this one, all of these still aren't going to get it. It's just one more person out of 1,000. Okay. Now, something else though. In terms of endometrial cancer, it's actually protective. So people who have continuous combined HRT, it actually goes from 4 in 1,000 to 1 in 1,000. So it reduces risk, all right, compared to those that have never taken HRT, right? So just a couple of things to think about in terms of relating to others and interpersonal skills. That, it's really important that we show a lot of empathy, because the impact of menopausal symptoms can be huge. It can impact their relationship, it can impact their confidence at work. They were feeling embarrassed. It's impacting their mood. They're feeling irritable. She's got valid reason to be worried about dementia because of family history and because that is something that is got a genetic component. So one of the things is to give clear evidence-based reassurance. So, you could actually do one of the approved cognitive function questionnaires, like 6CIT, and say, look, actually, you've got a perfect score in this. This suggests that you've got no loss of, but we could keep an eye on this. If you do get worsening of that, come back, because there is a risk factor, there being a family history. Okay. But what you've got fits with perimenopause. When you're asking some of those intimate or personal questions, it's important that we signpost. Before you ask them, you let them know why. I'm going to ask some personal questions now. The reason I'm asking them is that actually it can give us a clue about how it's impacting you, but also about there's different treatment options that could help you with these symptoms. But we also want to rule out rare but serious things. And it's there's a balance between giving the right information so that they can make the choice and empowering them to sort of raise their own concerns, to look things up, to come back with more information and make an educated choice. And, we want to be collaborative in our decision making. So involve them where there's different options that would fit their situation. If they've got a preference, we can go with that. If they prefer a tablet compared to a patch, for example, we can clarify that. And if it's possible for their circumstances, sometimes a patient, for example, might have a reason why they can't have something. Let's say they had a history of breast cancer. Now, some of the options might be no good for them. We could explain why, and we could look at alternatives. Okay. So just really to wrap up then, and I'll take questions. If you've got questions, put them in the Q&A. But just to say that, we've got lots of things to offer support for the SCA. We've got our SCA casebook, which was the first dedicated casebook with mark schemes mapped to the SCA, which is different mark scheme to both RCA and CSA. So, all of our cases were updated, and each one's got a detailed script for whoever's going to be the simulator in the group. Each one's got a doctor's sheet in the same format as the exam. And most importantly, each one's got a specific mark scheme for that case with mapped to the right domains for SCA and links for further reading and learning points. Okay, so it's 400 pages. There's 75 cases, including there's cases mapped to all 12 domains. And at the back, we've got 12 cases arranged as one full mock SCA, so that each of the 12 map to the different domains. Okay, so for UK delivery, you can just get that from our website. I'll just show you. We've got a section for SCA here. You can find the casebook there. So for UK delivery, you can get it from us. For international delivery, you've got two choices. If you want the printed book for international delivery, then if you type in MRCGP SCA into Amazon, ours usually comes up at the top, but you'll see it's there. Okay. This is available for international delivery. If you order from us, it's only for UK delivery. And then the other option is that we have the SCA cases online. The same 75 cases are available online, where you can just access it from anywhere. With that, there's also a couple of consultation videos and an overview of the exam, how examiners mark, how to structure a consultation, and so on. We've also got a GP 100 case crammer, which has got 100 cases. And a bit like today, how we've discussed the key learning points, what are the key questions, red flags, examinations, current guidelines for management, clinchers to make the diagnosis, things to think about in terms of relating to other interpersonal skills, what red flags you absolutely have to make sure you don't miss, things like that. It's 100 cases. Actually, the case we've done is adapted from a different variant. We have got a case about menopause, but it's a different situation than this one, okay, from one of those. So they're in blocks of 5 cases. In total, it's over 8.5 hours worth of videos. Every 5th case is an interactive case. So like now, there will be a simulator. You'll see the audience is asking questions and you see them answer live. And it comes with a 362-page PDF course booklet with the summarized teaching slides. Okay, these are the different cases within that. And then we have our flagship live SCA intensive, which runs roughly once every month or once every other month. You get to see 20 role plays throughout the day. We've got both male and female simulators. You'll all get one full mock case with detailed individual feedback, and you'll also get involved in an interactive case where you do part of a case, focusing on some areas, and you'll get feedback on that. Okay, and you can see all of the different things that we do for SCA here, because we do have various bundles. So just on the eMedical homepage, the whole section for SCA, if you click that, we've got our intensive, which is available with a bundle with some one-to-one coaching and 3 different books, the GP100 printed book, the SCA case book, and another book of cases from Scion Publishing, or just the course, or that with a bundle with various other things. We've also got our Past the SCA bundle, which has 3 SCA case books, and then 12 months access to our SCA masterclass recording and the GP100 case videos, and various other things. Okay, so we've got all of that there. Just to summarize, look, in every single case in the SCA, all 3 domains are assessed. So there's data gathering and diagnosis, there's clinical management and medical complexity, which is the domain that's weighted the most. That's worth 50% more marks than the other domains. And there's relating to others, which is communication and interpersonal skills. Okay, you need to be focused in your data gathering so that you have enough time to deal with management effectively. And your interpersonal skills, you're relating to others, that's assessed throughout the whole consultation. Like any skill, you need to know the basics, you need to gain the knowledge, but then you develop a skill through practice. So, if you put the practice in, prepare, and you will succeed.